Wes, you're back. Thanks for coming on.
Thanks for having me.
Everybody, this is Wes from New Hampshire, EMS lieutenant for a fire department in New Hampshire, and a flight medic from up there as well. So we're going to do some listener questions because I don't want to be the one that talks all the time, and Wes is a smart guy. And when we were talking about doing this episode, you said you wanted to talk about CPAP versus BiPAP. Who needs CPAP versus who needs BiPAP? So why don't we start with what's the difference between the two? Because your everyday, like, entry-level 911 medic may not know what the difference is.
Yeah, sure, of course. So when we're talking about the difference between CPAP and BiPAP, CPAP is a continuous pressure. We put a mask on a patient, hook it up to a ventilator or some sort of box that delivers pressure, and a continuous positive airway pressure is one set value that we start with, usually 5, and titrate up as needed. And it is just one value. And then bi-level or BiPAP, depending on which company you have, is trademarked, is going to be setting 2 values. You're going to provide that same expiratory pressure they're breathing against, but then bi-level, you're going to add an inspiratory pressure as well. Is that a quick
Very
down
good.
and dirty?
Why would you use BiPAP as opposed to CPAP?
So the way I try to think about it and the way I try to disseminate it. All right. So the way I try to think about this and disseminate this to people is to think in the simplest terms because it's the easiest to absorb. I try to think about deciding whether somebody needs CPAP or BiPAP based on if they're having an oxygenation problem or a ventilation problem. So let's paint a picture of your 70-year-old, poor medical history, that's quite overweight, that has huge +3 pitting edema, and you can hear them breathing through swamp water from the door. You throw them on the SpO2 and they're at 78%. That is an oxygenation problem. And the way we fix oxidation problems in medicine is with PEEP and FiO2. So if you throw on a CPAP,
correct,
you get them PEEP at 5 or 10, and you put that on a 100% FiO2, and that would fix your oxygenation problem. It doesn't push the fluid out. If you think about your 68-year-old 3-pack a day smoker that has a history of COPD, they have a ventilation problem. And a ventilation problem is benefited by assisting that patient with BiPAP to create 2 different pressures. So you're helping them inhale, and then you're also stenting open the alveoli with that exhalation pressure. So you have 2 different pressures, with your inspiratory pressure and your expiratory pressure being different. The number between the 2 is your delta pressure. Your delta pressure is the tidal volume that the ventilator is moving in and out. Think of that as a mechanical BVM that the patient is controlling the rate. So if you find that you put them on, the nasal cannula, whether it's on or end tidal on a nasal cannula or an inline, and you see whatever their value is or their air trapping, and that you need to adjust to assist them with their ventilation status, you then increase the inspiratory pressure and maybe increase the expiratory pressure a little bit, but you need to keep changing that delta pressure to be larger to assist with their ventilations. So that's how I try to do that, is the simple explanation of the 2. And obviously you could have your CHFer that's got terrible pulmonary edema that clearly has an oxygenation problem that then turns into a ventilation problem. And that's where we're going to use clinical judgment down the line. But what I like to do is start with CPAP. We use the Zoll Z-Vent. Start with CPAP, try adding pressure support, and then eventually move on to BiPAP, depending on how they respond to that.
Do you guys have it in your protocol to use BiPAP?
Yeah, paramedics do. EMTs and AMTs can only use CPAP.
Well, in Pennsylvania, which is one of the least progressive states in the country, and it's changing supposedly, because thank God that old medical director Kupis is gone. He was the guy who said, "It's my job to protect the public from EMS." Like, there's a freaking leader there. Yeah, dirtbag. Anyway, yeah, with the new medical director, much more progressive, and supposedly we're going to be getting BiPAP, but no, right now we just have CPAP.
Oh, okay. Nice.
But yeah, BiPAP's more comfortable for the patient. It
is more comfortable, and it is more finicky. It's delicate. you have to have settings just right. It takes a bit of finesse and time, and you have to read through some alarms to get them comfortable. That's why I like
That's
doing the CPAP.
exactly what I was going to say.
Okay, yeah.
Yeah, BiPAP is a pain in the ass for transport because, as you said, it's finicky. You got to troubleshoot it. Some of the alarms are going off. Sometimes the patients need a lot of coaching, maybe even some analgesia or sedation to adjust to it. But with the transport ventilators that are on the market, honestly, with the exception of the Hamilton T1, they all kind of suck at it. You know, I used the Revel for a very long time, and if your patient's really air hungry, or if they're pulling a ton of minute volume, some of those motors in that vent aren't going to be able to keep up with it.
Yeah, yeah, exactly. It's not uncommon when we put somebody on BiPAP and we decrease the trigger so it's easier for them to breathe. We decrease the rise time. We see then all of a sudden the respiratory rate alarms going off, so you have to adjust that really quick. But we'll see tidal volumes measured at like 1,600 mLs, and it's like I can't imagine that's actually going in, but it's measuring that somehow, and I'm guessing there's an error in there somewhere. But
You know what it is? I was talking to a respiratory therapist who now sells Hamiltons, and he said those huge tidal volume and exhaled tidal volumes that you see are air leaks from the mask.
oh, interesting. All right. Well, that's
I know it's not the case with the Revel. I don't know about the Zoll. He said that the Hamilton is able to compensate for an air leak of something humongous. So while you're getting those erroneous exhaled tidal volumes and stuff, it's not affecting the patient, and that's not a true exhaled tidal volume. So obviously you would try to mitigate the leak, but the patient's still
right.
going to
Right.
get the ventilation.
That's understandable. The Zolv Z vent, when leak compensation is on, it allows like 30 mLs of leak from the mask, basically, but that's not quite a lot.
Do the medics like using BiPAP, or do they just all put them on CPAP and say, "Oh, we didn't have time"?
We had an interesting rollout with it. When we first put it on, this is before I went to go fly, it got on the trucks, and our education for it was not as detailed as I think it could have been. And we had Zoll come in and try to do an update or some sort of secondary rollout with education. And the educator that came out is a phenomenal guy. I know him pretty well, but he was talking at the RT level and not the street medic level. And so we had a lot of struggle with it. A lot of people refused to use it. Understandably, we kept that yellow thing on there for a while, so they were just using CPAP. And now what I'm seeing through QA is we're having great success with it. And actually, respiratory and a couple of the attendings this past week passed along kudos to the crews on their vent management with BiPAP patients. But we have done quite a lot of training, and we still have more to do. But we are getting much more proficient at it.
Yeah, that's awesome. Another good thing about BiPAP is that you can titrate the FiO2. Now, you can on some CPAP circuits, but on the majority of ones that are in the pre-hospital environment, they're powered by oxygen, and it's a D or M cylinder oxygen tank, and it's 100% FiO2, which the patient may not need, or we know that hyperoxia can be a bad thing. So let's say I have some metabolic acidotic patient, like a septic shock patient or a TCA overdose or a ethylene glycol toxicity that's breathing 40 times a minute to compensate for their acidosis. Well, they don't have any oxygenation problem. They probably have more oxygen in their body with that 21% ambient air and their rate of 40 than they could, than they need anyway. So you can just put them on the pressure so you're not giving them any more oxygen. So I like that with the acidotic patient. BiPAP's great. You could just put it on them, and just give them the minute volume that they need.
Yeah, absolutely. That's perfect. I like that. Yeah, so that's my down
All
and
right.
dirty with CPAP versus BiPAP.
Excellent. Let's go to this one. Another clinical question. This guy asked me this, and this is as common as, does albuterol cause pulmonary edema, and does CPAP push fluid out of the lungs? What this listener asked what my thoughts were on Narcan before ventilations And does that cause pulmonary edema? And I've never heard specifically that Narcan before ventilations will cause the edema, but I have heard plenty of times that Narcan will cause pulmonary edema. And obviously, you should just ventilate the patient. You should ventilate the patient before you give them Narcan.
Yeah,
What say
that
you,
right
Wes?
back to the ventilation problem. I totally agree. They need to be ventilated first. That's a really specific question about asking Narcan before the ventilations. No, don't do that. Like, don't do that, please. And then we can talk about the
Correct.
rest of the question later. But for anybody listening, don't do that. Um, so I have never had somebody that had pulmonary edema after I gave Narcan. I have heard of it happening. I did a quick search on Google Scholar recently, and there's plenty of info about it. But the mechanism is really unclear. I did jot down one thing that I found from 2 studies in 2020 that they said the proposed mechanism for this is that Narcan triggers a centrally mediated catecholamine surge, which results in an adrenergic crisis. This shifts blood volume from systemic high pressure bed to the pulmonary or low pressure bed, which increases permeability and subsequently pulmonary edema. You know, again, it's a theory, it's a proposed mechanism. I have read that it does happen. I haven't seen it personally, so I can't give firsthand experience to it. All I found was just these studies that said it can happen in young, healthy. There was an instance of a 22-year-old male that went in for a shoulder reduction, got too much sedation during his procedure, got Narcan. After that, they found there was bilateral infiltrates, and they had to intubate him and keep him on PEEP for a while.
Here are my thoughts. Working in the Philadelphia area, and doing this for 22 years now, I have given Narcan hundreds of times, if not over 1,000 times.
Yeah, I was going to say, probably.
I have only seen one patient that I personally have given Narcan to start to get worse shortness of breath, crackles, and then I had to put him on CPAP. I've transported, doing interfacilities, a handful of patients who were overdoses and then had to be put on BiPAP in the hospital because they developed pulmonary edema and they were in ARDS. I gotta ask though, is it the overdose or is it the Narcan that's causing the pulmonary edema? Because an overdose can certainly cause ARDS. And now this is just anecdotal, but I have been to many dead heroin overdoses, DOA, that had a bunch of pink froth coming out of their nose and mouth when I got there and I pronounced them. Clearly pulmonary edema. So is it the overdose? Also, I'm familiar with those references that you just read. It also says somewhere, it's either in them or in another one. I talked about this on a past podcast, but there's no good data on it. It's all like case reports and retrospective analysis. And they seem to all agree that higher doses of Narcan are needed, or pulmonary edema is associated with higher doses of Narcan. One source said like over 4 milligrams. That's a lot of fucking Narcan to be giving to somebody.
Yeah, no doubt.
So I gotta ask, is it the overdose or is it the Narcan? I don't know. I speculate that it's the overdose.
Right, and I would agree with you. With the greater the concentration of the substance that made them overdose is going to directly relate to more people giving more Narcan. So I could see where the people on that side of the fence are arguing Narcan is what caused it, but I can see you saying the overdose is what caused it. I had read something a while back, and this was during our kind of area, the epidemic of overdoses, but it was something to the effect, and I couldn't find it again, but it was the switch from positive pressure ventilations after giving Narcan to the transition to negative pressure ventilations, where somebody takes that first breath against a closed glottis and basically creates an imbalance between the oncotic and hydrostatic pressure. And again, that was going from memory, and I could not find the data on that. So there was explaining something, and this is again from memory, but it was explaining why it's a delayed effects. Like, hours after they have been resuscitated, they end up in the ED with pulmonary edema. But again, no good data that I could find today on that.
Interesting. I would like to say though that I am not one of these proponents that's, don't give the Narcan, just ventilate them. Like, no, give them the freaking Narcan. Yeah, obviously you ventilate them, but
First,
I I know that there are some people out there that are like, oh no, you should just intubate and ventilate the opiate overdose patient. If you did that and walked into any Philly ER with that patient and said, I need a critical care bed and a vent because I didn't give Narcan, they would rip your fucking head off and then throw it down the hallway.
I would imagine any ED anywhere in the United States or maybe the world would do the same. I would hope they would at least.
Yeah.
So that's all I got on that one. I don't have a ton of experience with it. I've given Narcan plenty of times. I just haven't seen the pulmonary edema afterwards. But
yeah, and I also think with the proliferation
times, so
of community Narcan,
these people are asking
you would be seeing a shit ton of pulmonary edema with all these patients. Because I can't tell you the last time I've gone to a DOA from a heroin overdose, because they all get community Narcan. The son lives with the parents. The parents know he's got a heroin problem, so they have Narcan. And they find son unconscious. They call 911. We get called for a cardiac arrest. And they give Narcan, and the patient's up and talking and bitching by the time we get there.
That is the majority. We have seen a few overdoses recently where the person's been dead once we got there. But yeah,
it's been a while for me. But
I actually had
I don't know how it is up by
Thousand
you,
Island
but
dressing
everybody's got
thrown at me the other day
Narcan
for the first time when telling a person's
pet.
That was a overdose in the middle of the night on the toilet, and they found him first thing in the morning. And he had, he'd unfortunately passed hours before, but the family was so used to him being resuscitated by the time we got there that they had a hard time accepting that it wasn't an opportunity for that this time. So yeah, so then I gave the news, and the Thousand Island went flying at me, and that was
it a ranch house?
It was, yeah, actually, with the lid off for whatever reason.
I think I also said to you then, did you use the salad technique when you guys managed his airway?
Actually had a line of those. That was beautiful.
Yeah. Yeah. All right. Let's move on. Everybody is talking about this advancing the profession of EMS and degrees, the paramedic practitioner. I think everybody knows my stance on all this, but what do you think?
Yeah. So this is my take on it. I do, between the flight job I was at and then now this job, got involved with QA a bit. And just from the QA perspective, you can see in somebody's narrative their level of education. If you look at a guy who has a master's degree in whatever, he's using different terminology. He's actually using punctuation, which is great.
Grammar counts.
Actually describes a very vivid scene where somebody, it's just the people that haven't had to do as many research papers or do as many essays, they write things different in a simpler fashion. And granted, there's always variants. There's people that are highly educated that write a very short narrative, and that's fine. But I think that going to college and getting even an associate's degree teaches you how to write paragraphs, how to write essays, how to perform research, again, how to use grammar. These things make us look more professional. And if the goal in the future is to make this profession into a recognized and respected profession, if they look at our charts and see that we're misspelling or writing like an eighth grader, I think that if we're looking to be looked at as a profession, we need to be professional, and part of professional involves education and formal education in a way. And I was going to talk about the pragmatic paramedics, which you've been a guest on. They did a couple episodes recently on this with a guy named Max Dodge, who works up here in New Hampshire at the fire academy. He was my instructor for my instructor classes. And if you get an opportunity, they're like an hour each. It's kind of long, but he does such a great job of describing the history of education and healthcare.
Sounds like a
Particularly,
porn star, Max Dodge.
I know, it's really cool. He's a good dude. But he said basically they just got to a point where they said in order to sit for the NCLEX, you have to have a degree. And it'd be just as easy for the National Registry to say you can't test for this until you have an associate's. But if they did that, would that make us better? Would that make us a profession? Would that make us more respected in the community? And that, I don't have the answers to that. I'm not a subject matter in that by any means. But what do you think?
I think you make a really good argument. I had my shift partner, Jake, on a couple weeks ago. He went to a 4-year paramedic degree program, and he said that he thinks there's value in it and that it made him more well-rounded. I think you're definitely right about grammar counting and, not sounding like a moron when you're writing a report or and, conveying information. On the flip side, though, I think there's a lot of crappy degree programs out there, and I think that any moron in America can get a degree in whatever they want these days. So I think you make a great argument, and I totally agree with you. I'm just trying to think like in practicality, whether, I went to the University of East Ozark Plateau of the Regents, and I got my bachelor's. What's the level of academia there? Yeah, I don't know. I'm skeptical about the degree thing. I don't necessarily think it's going to fix paramedic education. I think it could help with the more well-rounded aspect, but where do you go with the paramedic education? God, we have instructors that don't know what they're teaching.
Yeah, and we've spoken about that at length many times. It's a weighted subject, and thankfully, and hopefully, there's people. If you go listen to Max Dodge talk on that podcast, he has far more interest in the subject than I ever will. He has far more experience in it than I will, and I'm hoping that there's more people like him out there fighting for this to help move the profession forward. I'm not that guy, though.
Yeah, I'm definitely not going to be one of those advocacy people. I shit on them. There is a definite role for them. Somebody needs to be going to the council people, the Congress people, blowing them and, securing, I should say it, securing funding for us. But no, there is a role. Actually, my friend Ben is a state public safety administrator up your way, up in New England. And he said that he hates his job and it sucks his soul out, but he's really good at it. He said, I am really good at finding the money that is out there so that the troops can do the job that needs to be done. He's like, it kills me not being out there running the calls, but somebody needs to do it. I'm good at it. A very, very necessary job. But some of these advocacy and professional advancement organizations, I look at their agendas, I look at the reports they publish. There's not a lot of substance in some of them.
It is tough to see. It's tough, and you wonder if maybe if you sit on one of those, if you're going to get more out of it than what the print says. I'm not sure, but again, thankfully there are people like Ben and people that are involved in all these committees and groups that are doing the work because they're doing better than I ever would.
I don't know. One of them they really got pissed with that tiger meme I posted. One of them was very, very upset and is very burned that the Instagram algorithms allow lesser people like myself to get more of a following. You ever looked at the likes? I know I'm sounding petty here, but have you ever looked at the likes on the NAEMSE or the Joint Commission's Instagram page?
Oh yeah.
It's pretty sad. My 11-year-old posts videos of him playing Minecraft to TikTok, Minecraft and Fortnite, and I mean, he gets more likes on one of those videos than they do in a year. But anyway, I'm just being a dick.
It's interesting. Maybe the people that follow them don't understand the value of hitting the like button. I'm just trying to give them the benefit of the doubt. I don't know.
I threw this in there because specifically for you. And I've been a supervisor before, so I definitely could see both sides of this coin. Showing up on your people's calls, does it piss them off?
Ultimately, I will say I don't know because they haven't told me it pisses them off, but I do know plenty of them would. Now, when I was on the floor and I was on an ambulance and I was on my 8th, 10th, or 15th call of the day of back pains, abdominal pains, because we did BLS, ALS all in one. All paramedics were doing BLS stuff as well. And then something of high acuity came in, and then 4 other people signed on. There was a bit of initial like, oh, so you come out for this, but you didn't come out to support me for the other 15 calls. And then once we're in the back of the bus and there was people that were capable in helping me and drawing up meds that EMTs and AMTs couldn't do or preparing equipment, it was beneficial in my view only. So when I came into my position of now training and mentoring.
Hold on. You there?
Yeah, I'm here.
Yeah. Yes, I see what you're saying. It does burn me when the supervisor shows up on a shooting or a cardiac arrest and it's, where were you at the nursing home across the street? Or where were you when an ambulance from out of district was coming in to cover us, going to a call
Exactly.
across the street from the station?
Right. And I take that stuff to heart, and I spend a lot of time at nursing homes and go to all levels of acuity to those because we're working with our nursing homes on what's appropriate and what's not. One of the things that I've been doing is being, if it's an out of town ambulance, like you said, coming in, I would go there first and get vitals. If it's a car accident, I'd go and do some sign offs. I tried to be what wasn't there when I was a medic on the ambulance.
That's good. Yeah, perspective. I think there's a dichotomy because if you don't show up ever, they're gonna go, this guy is not, he's a paper paramedic, he's out of touch. But if you
Right.
show up
And
too
also,
much, it's gonna be a pain
more
in the ass.
more importantly is what do you do when you show up, or what does a supervisor do when they show up? If I were to take the position where I went into the call and tried to take over, that I would very quickly find out that I pissed the medic off or the crew off. If I'm
Yes.
showing up with support and I'm going to wait to do what I'm told and basically let them delegate stuff that they don't want to do, or that if they're setting up their airway equipment, like yesterday, I was pulling up meds to do the RSI, and that just lightened the load on that medic for him to cognitively offload that task, not have to think about it. He was able to figure out everything else and work with the rest of the crew. So I think
Yeah, a good supervisor showing up says, what do you need?
yeah, and sure, and that it's not what I'm not trying to be a good supervisor. I'm just trying to show up and be what I didn't have for a bit. There was one supervisor that did really well, but just show up and be an asset. Like I showed up at a routine call, a frequent flyer, and I had a Tyvek suit on and went in and got covered in poop and helped her out of the house. And because I think it's important to be part of that crew, but not taking over the call is what a supervisor should be doing.
Yeah. You also, though, you don't tell the people this, but you also have to go do some eyeball leadership and make sure that people are, one, doing what they're supposed to, and two, seeing if there's any knowledge gaps that you need to address.
Yeah, there's definitely an aspect of that. I thankfully haven't had to employ that, but it is something that one of the station captains, when I showed up to a nursing home early on when I first got hired, I said, I'm not really sure why I'm here. And he says, it's clear they just need some administrative eyes on the situation. And it's not that I'm looking at the crew or nitpicking them, but it's looking at the bigger picture of, is this working? Do we need to change our policy on this or that? Or what education do I need to provide to the state or to this nursing home or something like that? So when I show up, I try to just be fly on the wall and help as little as I can or as much as they need.
Yeah.
But I know we've all had supervisors that show up and try to take over the call or instantly tell us we're doing it wrong.
That is the worst. 5 minutes into the call, they show up.
Yeah.
And start barking orders. It's like, hey, yeah, we're good. We were good as soon as we got on scene.
Exactly. Yep. Yep. But that's what I got for that one. I respect that one for sure.
Yeah. All right. This is the last question. I am a new flight team member. What are some tips for succeeding as a new member of a flight team?
Yeah. So I did this recently. The number one tip that I have that I learned and like to pass on to people is understanding the humility of that level of medicine. And I heard you say this, or your guest on the last podcast, and you don't know what you don't know. And as a new flight provider, you need to ask questions because you're working with people that have been doing critical care for some time. You're working for medical directors that are arguably some of the brighter and hopefully most down to earth people. And you're working on protocols or under protocols. And I've been part of these committees where they write each word in a protocol is scrutinized. But when you can appreciate it because they care that much. And these people want to see a new flight member succeed. They want to see that all the flight teams succeed. So being part of any sort of education, asking all of the questions is vital to your success. And the big thing, like in anything, is study, study, and study. I mean, flashcards for meds, practice your procedures, flashcards for your lab values, and ultimately know your resources because you're not going to be able to know everything that they want you to know. One of my supervisors, when I started flying, told me that our expectation is that you will be working as a third-year medical resident. Third-year medical student. So you have to go from a street paramedic to a third-year medical student in about 3 months, depending on how your program does the orientation.
I'd say the resident is actually more accurate because we're there doing procedures.
Yeah. Yeah. My first chest tube, the physician at the sending facility moved aside, and I was like, I'm supposed to be the expert in this? Jesus. It's very humbling. And so ask all the questions, practice, don't have downtime in the hang. Ask all the questions, practice your procedures. It's going to slow down a little bit at month 2 or the end of month or middle of month 3. Towards the end of your orientation is the time you need to focus and study even more because you're about to be let loose and trusted with a vast new set of protocols and skills, and those need to be honed in. So the best thing I can say to somebody new is get your head in the book and keep your head in the game. When you have downtime on shift, you're asking questions and you're practicing your procedures, and you're reviewing your protocols.
Definitely. What about the flip side? I get asked a lot from flight nurses, what advice do I have for scene calls? Because that's totally foreign to some of them. So let's say you're working with a new flight nurse. What are your points of advice, your pro tips?
What's interesting, I love this because I got hired with a fantastic nurse, and she learned pretty fast. And then after our orientation, we started working together a bit. And so we got to do some scene calls, and it was a lot of fun. She didn't have this problem. This girl, shout out to you, Faith, just squared away. But what I've heard happen at this program and other programs is that when the tone goes off, you literally have to tell a nurse, you have to go to the helicopter. You have to leave your area of safety, which is in that hospital, because they've never done a call to a response before, unless they've been an EMT or something. So there is a gap that you have to facilitate and let them know, or kind of take them under your wing and show them what it's like to go out away from the hospital to extend the resource of the hospital. I think the hardest thing for them.
Yeah. Yeah, no, definitely. You take them under your wing, but I have also found that I'm doing more reassurance and coaching with new flight nurses than I'm doing with, you know, follow me, here's what we're going to do. I can remember, I know Alyssa listens to this. She was a new flight nurse. We had a pediatric RSI we had to do with some multi mass casualty incident. And she told me later, she's like, I was scared shitless. And I remember telling her like several times on and after the call, like, you're doing great. Like, you're practicing medicine, you're following the protocols, you're doing all the right thing. Just because we're not at the bedside in the hospital does not mean that, meds aren't meds or the intubation procedure is different. Just do what you know. That's how to take care of patients.
Yeah, absolutely. And I think, it might, and this might stir some or ruffle some feathers, which I don't think is something new to your podcast, but I think there's a steeper learning curve for a nurse learning to be a medic than a medic learning to be a nurse. And the reason I say that, my perspective is I was worried sick when I started flying because I had so much ICU stuff to learn, so much nursey stuff to learn. But that stuff was happening inside of a hospital where I would ask somebody for resources or for help, and there was people there to help. And from the paramedic side, teaching a nurse to be a paramedic, you are the resource. The foundation of working as a paramedic is being an EMT and having built this relationship with patients and yourself where you are guiding the call. It's one-on-one provider. And this, I'm going to tie into paramedics need to be EMTs before they're paramedics. Because you're working
We'll agree
alone.
to disagree, but I'll hear you out.
Thank you. My opinion is you're working alone without resources. A nurse can go to nursing school and learn how to be a nurse inside of a room with lots of resources and a call button. And there is no call button in an ambulance unless, your system might be a little bit different. But
while we're ruffling feathers about this, Bill, my flight nurse partner, he was a medic for 20 years before he went to nursing school. And he's been a nurse for 25 years now. And he's worked all over. And he straight up on one of the episodes was like, it is way harder being a medic than it's being a nurse. And I've never gone to nursing school. Granted, it's tough. But
I'm sure
I've got to say, every single medic I know that has gone to nursing school has been like, the time commitment is a bitch. But academically, like, dude, this is a breeze.
Right. And I am in no way talking shit about nurses or nursing careers because they're vital. But that was just my kind of, I think the foundation of being a paramedic is being an EMT first, because you are the only resource and you're learning to manage things one-on-one without help.
Well, not that I agree with the EMT before paramedic approach all the time, but to your point, 85% of being a good paramedic is being a good EMT.
Sure.
And if all your fancy tools, your RSI fails or, whatever, what do you fall back on? Your BLS skills. Right. If I can't get access and I can't give a bag of blood to someone to address their hypotension, like, yeah, that's bad. That's not optimal for the patient. But at the end of the day, if I don't do good BLS and I don't put a tourniquet on that patient or stop the bleeding, they're going to die.
Right. Absolutely. I can't agree more. So I kind of sidestepped there, but you're basically providing for that nurse partner the foundation that they may not have had if they were not an AEMT. So you're passing on that knowledge that you have had through being a paramedic, through being an AEMT or an EMT on scene management and decision making. And that sets them up for success.
Yeah. There's also, if I'm being totally honest, and this might be a little reassuring for those nervous new flight nurses who have messaged me, there's not a whole lot of scene management you have to do as a flight provider. Granted, it could be different out in the middle of nowhere, but typically when we're landing at a scene, incident command's already been established. They've already done the scene size up. They say, hey, your patient's in that ambulance over there, or hey, they're still trapped in the car. They're working on extricating the patient now. It's not like, I think it's much more hectic, and there is a hell of a lot more scene management that goes into responding to a diabetic that's unconscious on the third floor of a city house than there is as a flight provider showing up at the scene of a giant accident.
Oh, without a doubt. I had far less stress as a flight medic on scene calls than I did as a paramedic in a 911 system. Every single
Totally.
day, every single call. You're a specialty resource. You already have information. You have some sort of vitals. You probably already have access. You're going in and just doing some things that their protocols don't allow them to do. You're not making, there are times you're making some crazy decisions, but it's far less
Yes.
frequent than a 911 medic. For
Correct.
sure.
Yeah, I think one of the good things about New Jersey, I always bitch about the New Jersey system. Actually, they just changed their protocols, and I have to say, New Jersey is no longer a mother may I state. The new protocols, I think they're hectically laid out, and if you like looked them up on your app on the fly and you need them as a reference, you're kind of like, oh my god, what am I looking at? But as I say, the meat and potatoes of the protocols are very, very good. I mean, you used to have to call doctor for everything. But another good thing that New Jersey does is the nurses have to become MICNs, which is the equivalent of a Pennsylvania PHRN. Basically, they have to get licensed as a pre-hospital nurse, and they have to complete so many hours of a field internship on an actual paramedic unit.
That's pretty awesome.
And it has to be a 911 paramedic unit. It can't be like, oh, I'm going with the IFT company. And so that is one very good thing. I do think that since I've been on 2 flight teams now, one in Delaware and one in New Jersey, granted, we do way more scene flights in New Jersey than we did in Delaware. The nurses seem much more prepared in New Jersey because they go through that training.
That sounds like a phenomenal program. We don't have that up here, but that's pretty great. I like that. Yep.
I think we're at 45 minutes once I edit out all this stuff. So let me wrap this up. You got anything else, Wes?
Not right now, but if I think of something, I'll shoot you a message. Thanks for having me on, man.
Yeah. Thanks again for coming on.